I think the biggest step is just finding a provider, finding a physician, a urologist, and starting the conversation. I think really find that.
You're listening to In Your Pants with Dr. Susie G, the physiotherapist for your private, helping you get in the know, down the low.
Hi friends, Dr. Susie G here, and welcome to another In Your Pants podcast. On today's show, I have Dr. Denise Asafu-Adjei, who is a urologist. Her and I dive into men's sexual health through a public health lens. We also discuss gaps in care for men and health-seeking behavior and considerations of the social determinants of healthcare when men seek care for their health concerns, and particularly sexual dysfunction. Now, Dr. Denise in her office mentioned that she most commonly sees erectile dysfunction and male infertility. So we dive into erectile dysfunction, the causes, the trends, the lifestyle factors, and also the psychosocial factors that are involved with erectile dysfunction. We also dive into when to actually see a urologist and for what conditions. And particularly, we also dive into Peyronie's disease, talking about what it is, the symptoms, the current medical treatment offerings, the risk factors. And then lastly, we end our conversation chatting about the barriers for men to access care. Things such as the comfort level of both the provider and the patient to talk about sex. And also psychosocial and cultural factors like taboos and stigmas around talking about anything that has to do with our sex organs or our pelvis. So you don't want to miss this episode. It is jam-packed with so much wonderful information and wisdom from Dr. Denise. So I'd like to formally introduce Dr. Denise Asafu-Adjei by sharing her bio with you, which is quite impressive. Dr. Denise is a urologist with a subspecialty training in sexual dysfunction and male infertility. She completed a fellowship in Andrology at the University of California, Los Angeles. She has recently joined the Urology Department at Loyola University in Chicago as the medical director of male reproductive medicine. She completed her urology residency at Columbia University Irving Medical Center and received her MD from the University of Michigan Medical School. She obtained a master's in public health in health policy and management from the Harvard School of Public Health, and she also received a Bachelor of Science from Carnegie Mellon University. In the future, Dr. Denise aims to utilize clinical research and physician leadership to help healthcare systems achieve access to equitable and high-quality healthcare for sexual dysfunction and male reproductive services. She enjoys leisure international travel, musicals, golf, exercising, and cooking. So, without further ado, let's get this show started. Hi, Dr. Denise. Thank you so much for being on the show today.
Hello, thanks so much for having me. I'm so excited to be here.
Likewise, because we have a wonderful topic that we'll be talking about, and I'm so excited to pick your brain about it. But I wanted to first start to talk about, in your profession, as men's sexual health, and what really inspired you to get into, which is a very specialized niche of working with men like myself. So.
Right. Well, I think certainly within urology, everyone always thinks that, urologists like only deal with men, which of course is like not true. We certainly, treat women as well. I think particularly with men's sexual health, there's such a huge gap in care because men traditionally don't seek out healthcare as often as women do. A lot of times when we see guys outside of maybe their adolescent, visits that their mom forced them to go to, we usually don't see them again until something, really pushes them to have to see a doctor, which is really, the opposite of what we see with a lot of women who I think are a little bit more socialized to, not only be at the doctor, but we are seeing our gynecologist, and men don't really have that counterpart that they're really required, quote unquote, to see on a regular basis. So I think when I think from a public health lens, men are, really a huge, target area, a really big focus area that I think is, often missed. And when I think about this in the context of, the family, the American family, or, whichever family, with a lot of men, being, the breadwinners, although of course as a woman, I know that's changing now, but,
Mm-hmm.
in a household. So it's really important for men to be just as proactive about their healthcare as women are, because it really has a lot of downstream effects when, a household, loses, the dad, and, something else happens. So I think that's really been a big motivator for me to have more guys thinking about their health.
Oh, well, we thank you so much for being an advocate for men's health. Because in my field as a physical therapist and sex counselor, I have also recognized that there is a huge gap as far as access to care, trust in the medical community, and really just even if I do have a problem, where do I go? Because it's not really talked about. So I'm so grateful for the work that you do and for your voice in this community. As far as men's sexual health concerns go, can you kind of describe to us what you commonly see in the clinic? And yeah, let's just dive into those details.
Yeah, well, probably one of my favorite things to see are erectile dysfunction. I think, within my subspecialty, I see kind of a wide array of different sexual dysfunctions, with erectile dysfunction being the most common in that pool. I also deal with male infertility, also probably a whole other topic on its own, in terms of just it being really underserved across the gamut for men. But erectile dysfunction is really interesting in that, a lot of guys who, nothing, they may have a million health problems, but I guarantee you, for most of the guys out there, and I'm sure a lot of their partners will attest to, if they have issues with the erection, they will find a doctor to go to. And so I think it's probably, for me, one of the most rewarding things to treat, because you're not only restoring quality of life, in these men, but also thinking about their partner's quality of life. Presumably they want their erection to be functional because they are utilizing it with someone. And I think it's really important to think about that impact, on different relationships and their quality of life. So I think, you fix a guy's erections and it really, gives them a new lease on life a lot of times. And I think that's really important. I think we still tend to be a very kind of disease-centered society, meaning that it's like, okay, I'm okay just because I'm like free of some disease. But some people don't mind living with some of these things, but they're just like, I just want to have good sex. And so I think it's really important to, kind of think about it from that lens, from, quality of life. And so I think it's probably one of the, most rewarding things, to treat. Of course, there's also, lots of disparities on the female sexual dysfunction side. And I think that is also, I have some great colleagues in the field who are really pushing that forward as well. But erectile dysfunction is really interesting. And also, by the time a lot of guys get to us for erectile dysfunction, when you look at the causative factors for it, you're thinking about things like diabetes, hypertension. It's usually a red herring for other, really major diseases. So I think as a urologist, and also as, someone, who also has a background in public health, thinking about ways that we can also make people recognize that, yes, it's important for you to have great erections, but you probably also need to see somebody for your other health issues.
Exactly. And I'm so glad you mentioned two things: the quality of life factor, because having change in sexual function in any fashion or form is very distressing, right? Because sexual health, as we know, is part of the health paradigm, right? You have spiritual, physical, mental, and sexual health, which is recognized. And because we're not, in our, at least in our society and culture in the United States, from my experiences, is that we are not openly discussing sexual health and education, right? As like there's no standard around that, but also then, the sexual messages and scripts that a lot of men kind of carry. And when those expectations are not being met, because their health, or there's a chronic illness that all of a sudden, they're faced with, then that changes their whole sexual identity and sexual voice. So I wanted to talk to you about that and how you experience that in your
therapeutic relationships. And then also perhaps the cause, like when you're talking about the causes, what specifically are some diagnostic tests or scans and such that you have your patients go through so that other listeners who might be interested in getting workup done understand kind of what that process entails. Because I can imagine, and just from my clinical experience of working with men, is that there's a lot of fear around going to the doctor, thinking there's something life threatening, I'm going to say the word, cancer, because that I think prostate cancer is on a lot of penis owners' minds or prostate owners' minds. And there's a lot of fear around that of like, I don't want to know. Like, I don't want to know. I'm just going to deal with it. I'm going to live with it. So I realize I just kind of gave you a lot to unpack there. So I'll let you take which side you want to start with first.
Right. Yeah. Well, I think I'll certainly start on, thinking about, erectile dysfunction, and I'll swing back to kind of societal norms and kind of misnomers around that sexual identity with men. So with erectile dysfunction, interestingly, and you kind of pointed to this now too, it's not just like a disease of like old men, right? We actually see a lot of young guys, in their 20s with erectile dysfunction. And so I think as, even though it's something that can really instill fear, I think it's also awareness that it's not just something that's going to happen to you when you're 60. A lot of things that you do to your body now will have downstream effects when you are in your 60s, but we see plenty of men who are pretty young. And I think because they haven't really, come to terms with like, wait, I could be in my 20s, but I could also have erectile dysfunction. And then it also has, it almost has like this vicious cycle of, well, I can't possibly have that, so I'm really not going to go to the doctor. And then you could have someone dealing with this for years and years who, we may have been able to, catch something or kind of treat it early on. With erectile dysfunction, if you look at our American Urological Association, guidelines in terms of things that we really think about, we really want to look at, we're always kind of thinking about the major causes around erectile dysfunction. So I want to make sure that, your cholesterol is not through the roof, that your blood pressure is not through the roof, like really basic checks outside of course, kind of assessing the history of, how long this has happened, the settings that it's happening in, because sometimes you can also tease out some other underlying things too. And it may not necessarily be like an organic cause, but it could be something, something else, medication or something like that. And so I think that's like the first thing that we delve into, but there isn't like just like one test that says, oh, boop, you have, erectile dysfunction.
Right.
It's, kind of a combination of different things that we look at that really targets the causes of erectile dysfunction. And that kind of helps us to be able to kind of treat the source of the problem first before, kind of thinking about other therapeutics like medications and such. Something that we look at in terms of just making sure that it's an underlying factor, testosterone levels. Good testosterone levels are really needed to have, good erections. And so that's something that we also see a wide range of that being kind of out of range for certain men. So on top of the, looking at, cholesterol, whether you have hypertension, other kinds of history things, that's kind of another thing that we look to. And we just kind of put everything into context. But I think for all the men out there, if this is something that you are struggling with, I think the biggest step is just finding a provider, finding a physician, a urologist, and starting the conversation. I think we really find that so many men are scared to talk about it. And the first step is just saying, hey, I think I might have a problem. And I feel confident that most of my colleagues and also just even like your primary care physician can really do a basic workup, for this to kind of get you, started, but nothing to fear. It usually is at worst, maybe some lab tests, but a big part of what we're assessing are, kind of the history and other things. So that's kind of the first part. The second part that you mentioned, I think, is also really important. When we think about how I think a lot of young men are really sensitized to have this like identity around being, these like sexual, prowess, I don't even know what to call it, but, these sexual gods. And it's just like, that's actually not reality for the most part. So I think, right. Unfortunately, even now with easier access, to pornography and other things, I think, a lot of our young guys are really early on thinking, I need to be, this rock star that I'm seeing in this, and then they enter relationships and it's either not that way, or their partners may not be fulfilling some of the things they're seeing in this. And then it just creates this really odd dynamic of, poor expectations and outcome.
Mhm.
And so I think oftentimes when we encounter men who've had a long history of thinking what they had to be, I think it's also resetting those expectations. And I think that's really a great place where sexual therapists are so key to be able to, I think, just help, people to reconcile that and kind of get back down to a level of, this is you, this is actually reality, and just kind of resetting the clock, so to speak. But I agree, it's a big issue. And I think realization is one of the earliest things we can get to start treating it.
Right. And thank you for pointing that out as far as just the expectations, the penis performance, or the performance aspect of sex, and sex looking a particular way, right? Because as you said, typically men will be told, like, you have to be your penis has to be ready to go whenever, however, doesn't matter, like what else is going on in your life, who you're with, like that's how you operate, right? And obviously we can't blame, there's no blame in that, because the learning, the knowledge around, like, how my body part works, for some degree is like men have more permission to explore with their body, to explore with this with the function of their body, especially their genital organs. And there's a visible, like, autonomous feature to that too, right? That's associated with certain contexts, etc. And so when that, again, like you said, when those expectations are not being met, or when there's a shift in perhaps health, or there's some underlying issue, then there's huge distress, and rightfully so, right? I mean, there's a lot of distress over, what's going on with me, my identity, what does this mean for my sexual voice, my partner, and in my masculinity, if I identify with that. And so I think all the things that you alluded to are so important to, for folks to consider who are listening, as far as, like, yes, there's a biological and health paradigm to this, but there's also the psychosocial, social cultural, the messages around our function. And it's interesting that you brought up too, that younger men are coming to see you for erectile dysfunction and difficulties. And I wonder how much of that is just, again, expectations or performance worry about, I have to perform in a certain way. And it's not, I mean, would you agree that it's not uncommon for men to have erectile difficulty, throughout their lifetime? Doesn't mean that they necessarily fall into a category of having, a pathological dysfunction, right? I mean, how would you, I guess, Dr. Denise, how would you determine that in your experience?
Yeah. Well, I think certainly it's also putting, every, patient, of mine is like an individual. Everyone is different. Certainly a 20-year-old coming to me having issues with erectile dysfunction, if everything else otherwise, it's, kind of healthy, no major medical issues, I'm not thinking the first thing is that, oh my gosh, she has some big cardiovascular issue that we haven't addressed. So I think you also have to put, that patient into context in terms of what you're seeing and what the, most likely causes are. Sometimes for my younger guys, for example, if they're just kind of starting their sexual lives, it's just kind of like riding a bike, so to speak, right? You're going to tumble a couple of times, you're going to try, and then you're going to get it going. And I think sometimes that reassurance is, what you need to kind of just, build that confidence up and get going. So you're right. Not every, cause of this is necessarily like pathological or something we have to chase down.
Mm-hmm.
Prudent for us to rule those out, as those are things that are at least correctable. So quite often we'll not really identify, like, the clincher in terms of this is what's causing it. And then we have to, like, really work around that. But I think it's just so important for people to, think about, like, okay, this is just an issue, and just really emphasizing just talking to someone about it.
Mm-hmm.
I actually really love the fact, like, platforms like yourself and a lot of other people in the social media space, before, I imagine 20 years ago, where probably a lot more people were suffering in silence.
Right.
At least now you can probably scroll through my page, your page, or someone else's, and at least learn the information. And even if you're thinking to yourself, oh, maybe I need to get this checked out, I think at least the the light bulb can go off a little bit more with, I think, more people putting accurate health information out there for people to see and for people to decide what I want to do about it. And I think that's something that also really, drives me, just getting the information out there. I'm sure there's going to be so many men that never come to our office, but at least they know the information can kind of go, from there. And something that you mentioned too that I wanted to point out when we think about like distress and around any kind of sexual dysfunction, everyone's also different in terms of even their baseline sex drive. And so I think for a lot of men who are, again, kind of socialized to be, I need to be, thinking about sex all the time, that doesn't need to be you. And that's also okay. I think sometimes we see guys who feel like, I'm totally comfortable, like me and my partner, like, we're zen, like, like we're good. And then, you may see something and it's like, are we supposed to be having sex 4 times a day? And it's like, everyone is different. So I think also being okay and being comfortable with yourself in that regard is important, that everyone is different. And you may not be the person that enjoys, maybe a lot of sex per se. That doesn't mean that something's wrong with you. Everyone is different. And I think it's also, we need to start normalizing that there's a range across that as well.
Absolutely. Well said. And a great point to bring up as far as normalizing that there is no normal. I know that sounds funny to say, but it's like, no, there is no normal. And it's really about being comfortable, confident, I said comfortable, but confident and safe in your sexual experiences, whether that's with yourself or with partner or partners, which brings me to kind of segue into the topic of Peyronie's disease, and because that can be a source of pain. And if we have pain in our body that is usually experiencing pleasure, then that becomes this conflict. So can we talk about Peyronie's disease first, what it is for those listeners that don't know what Peyronie's disease is, some of the potential causes and treatments that are available for Peyronie's disease?
Yeah. Well, Peyronie's disease, what I love now is I think that is really being put out there, whether it's, on social media, advertisements, like where guys are just like, okay, this is like a problem and I know there's something to fix. It's, essentially kind of a newly formed, curvature of the penis or any kind of a different disfigurement of some kind that's really caused from, a maladaptive way that, the penis into stress. So you have various layers that are outside that kind of line the penis, and one portion of it essentially, whether it's like injury, micro injury, what have you, instead of it just repairing like it normally does, it kind of goes into overdrive and forms like a little scar or scab, so to speak, in some guys. And so what guys are experiencing, and some people can really remember, I remember that one incident that happened and then my penis was never the same. Other times people don't have really, like one event they can point to. It's just like, they're like, hey, I just noticed it happened one day. But kind of the classic presentation is a pretty marked new curve in the penis, or sometimes any kind of, disfigurement along the shaft. Very, very distressing, a really high source of, depression in guys that have this. And as you mentioned, not every guy that has Peyronie's disease has pain associated with it. It is pretty classic, especially in newer presentations of it. But there are, some men who certainly are just like, hey, I just noticed that my penis was curved, or I had like a dent in my penis, and I just don't know, like where it came from. In terms of if you really think you have it, for my guys out there, I really encourage you to see a urologist, because there isn't just one blanket treatment for it. It really depends on, one, how long you've had it, if you are kind of having, what kind of symptoms that you're having and how distressing it is to you. If someone has a curvature, but they're still able to have pretty good penetrative sex, it may not bother them, so not every guy, they're just like, okay, it's a new change, but I can still kind of get on with my life. But if your disfigurement is so significant that now you can't have sex, it's painful to have sex, it's painful for your partner, then that's an issue. Peyronie's disease can also be a cause of erectile dysfunction. And so that's also something that can be very bothersome to guys, in terms of, now my penis looks different, and I, can't get kind of the quality of erection that I used to be. So it can be very distressing. But I think, certainly if you feel that something is different, particularly around pain, let somebody, kind of check it out and go from there. And then we can kind of do our workup around figuring out how significant it is, and then being able to talk about treatment. But treatments vary, across the spectrum, depending on how bad the degree of curvature is and the disfigurement. But there are things like injectable therapies, particularly if you have kind of the scab I mentioned, which you call a plaque. There's medication, you can inject into that to kind of dissolve that, so to speak. And then depending on if you have any concomitant, erectile dysfunction, then there's other treatments we can talk about that can kind of address both the erectile dysfunction as well as the curvature and grafts. And so lots of different treatments. But I think, certainly if you think that this is something you're dealing with, please, see a urologist. This is fairly bread and butter for us and pretty common. And I think something that should really be addressed, but very distressing. So I'm hoping if any guy even thinks he has this, please go and see someone. There's certainly great treatments for it.
Absolutely. And Dr. Denise, can you tell us what age range is typical or common to see with Peyronie's?
So Peyronie's is also something that can hit you at, any age. I'd say most of our guys that we see with this are kind of in the 40s, 50s, like our middle age guys. But we've seen certainly much younger guys get afflicted with this, and even, some older men. Think about kind of the age range where guys are going to be more sexually active, and potentially instances where you may have an inciting event, so to speak. That's kind of what we're seeing. But and 30-year-olds, like young guys, really young guys. But I'd say we really see it kind of in that middle age range, but it can certainly be younger and it could be older.
Okay. And how often do you see folks after pelvic surgery? Because from things that I've read, pelvic surgery or radiation treatment that changes the tissues around the sex organs can be associated or can change kind of the tissue and cause some scarring and adhesions. So is that something that you see as well post pelvic surgeries?
So post-pelvic surgeries, really depending on what was done. There have been some people where it's like they've had, a Foley catheter placed during a procedure, and then, or they had like a scope, they had some part of the procedure done that may have been an inciting event for something like Peyronie's. I wouldn't say your run-of-the-mill pelvic surgery should put you at higher risk for erectile dysfunction or even Peyronie's disease, but it really kind of depends on what was done. If this is something related to like vascular work, working with the blood vessels, all the vessels that feed your penis are in the pelvis essentially. So if you have something that may, nick a big blood vessel, that's certainly going to affect your, your erections. If there is some aspect of any pelvic surgery that's directly, maybe dealing with the shaft itself, that could, be kind of considered an inciting event, and that could be something, that cause Peyronie's disease. But I wouldn't say just a run-of-the-mill pelvic surgery should make anyone like worried that they're going to develop this. But putting into context, if other things are done, your erections are highly dependent on your blood supply. So that's the only thing where I'd say if that's, maneuvered or manipulated in any way, then, you could be at risk.
Right. No, thank you. And I'm sure that's for a lot of folks out there who are like, oh my goodness. And I can imagine just even the neural like the nerves to that area too, as far as erection function and quality, like in a prostate surgery or something like that could influence function or blood flow to that organ or use and frequency and, that sort of thing. I was also going to ask about your if you can speak to the theories around the autoimmune postulated theories of Peyronie's.
So, I would say right now there's still a lot of research being done on, Peyronie's disease. I think in terms of kind of genetic or, any kind of linkages, the one thing that we see pretty consistently linked with it are people with a history of Dupuytren's contractures. And that's something that we see pretty not uncommonly, if you're examining a patient and pardon me, and you may see, oh, have you noticed this in your hand? Or, they may mention it, but they don't think of the link. Actually, one of the major treatments for Peyronie's disease is also actually indicated for depoutrance contractures. And so it is something that we know is linked, but I think we know that with Peyronie's disease, it's an issue around basically how your body is responding to this point of stress along the penis and that inflammatory reaction. So I think we are still trying to figure out exactly what factors are, at play that may cause that. I wouldn't say that my men who have, other autoimmune diseases are like necessarily higher risk of acquiring it, but I certainly think that the theory, when we're thinking about what our body is doing in response to a stress, I think that's something that we need to continue to figure out.
Well, thank you so much for addressing that, because there's everything's so inconclusive, right? We're still learning, as you're saying, and so many theories. And when we're speaking to patients and people, it's hard to kind of present it in that way. Like, there's so many different factors that may or may not be contributing or perpetuating this cycle. There isn't just a single cause for the symptom that you're experiencing. And I think for a lot of folks, it's kind of hard to wrap your head around, as far as the multidimensional aspects of our biology. So it can be challenging.
Exactly. And I think that's kind of the big, picture view. I mean, I think, certainly if, a guy comes to see me, I'm probably not going to bog them down with a lot of the physiological factors that, may possibly be contributing to it, because I think our goal is like, let's figure out what's going on. Let's kind of see what will work best for you, just so that you can kind of also help to be their advocate and see how they kind of, want to proceed.
Yeah. Yeah. I wanted to know what your thoughts are about vacuum pumps and traction devices for Peyronie's. What are your thoughts in the pelvic therapy world? Yeah, I'll just speak from my experience of like, we often recommend, vacuum assisted devices, traction devices. And most recently we had a randomized controlled trial of ultrasound. So I'm just curious as to what your thoughts are on those potential treatments, in addition to perhaps the injectables for perhaps maybe a sustainable or more positive outcome in treatment.
Yeah, well, I love traction devices. I think certainly within the urology community, I think there is still a divide in that regard. I think, there's certainly a lot of great urologists who don't really love the data, surrounding it. But I think I'm certainly where, I was trained, I could certainly see that difference. And I think that's something that I certainly recommend for any patient that I have with curvature that has Peyronie's disease. A traction device is just kind of another layer that you're helping to really stretch out those tissues. And over time, you can kind of, we use a comparison of thinking about it like braces, right? Where it's just like over time, you're just kind of slowly straightening things out. Now, traction device, if you have a plaque for Peyronie's disease, it doesn't address, that scarring or anything like that, but it just helps, at least from a functional standpoint, helping you to, get a little bit straighter. So I love traction devices. I'm very impressed that you're recommending that to patients, because I love traction devices. They work great. And then vacuum devices, I feel, are also probably really underutilized. I think that's another kind of, tool in the toolbox. It's actually one of the kind of recommended therapies for erectile dysfunction, not even just per se, but it really helps to maximize blood flow to the penis. I think, unfortunately, I think it hasn't gotten a fair shot, probably due to kind of media, and I think it's association around the kind of sexual, industry, or even like pornography and things like that. But it works well. I think, we certainly use it in various capacities around erectile dysfunction, post even, kind of pelvic surgery treatments. And so I think it works really, really well, but I think it hasn't gotten a fair shake because it usually has some kind of shady association, or if you Google it, like,
so unfortunate, because it's penis rehab, call it penis rehab. you know? And it
Exactly.
is so unfortunate. It doesn't have to be sexualized. It's just another therapeutic tool to use. And you and I, in a situation of working so closely with our patients, is that we have the opportunity. We have, first of all, the knowledge, the anatomical knowledge, the biological, the physiological knowledge to be able to safely instruct and also follow through on the application of these devices. Whereas if somebody's most likely seeking it outside on a YouTube channel or some forum, that's where you can get injured if you're not understanding like how your body works and gradually introducing changes to your body for adaptation to occur in a safe way. Because you can go too fast too soon with some of these things. And it's really important to have guidance and a coach through this process.
Yes, I completely agree. And I mean, I think, pelvic floor physical, therapists are really kind of in such short, so, we've talked about this before. It's just like, you guys work wonders with our, with my male patients, with my female patients. Like I wish more people, can kind of access to those services, because it really makes a difference. I think, I certainly quite often, refer people out to pelvic floor physical therapy. I see that difference, and I think it can really be a great adjunct for a lot of, guys looking to either gain more control of their pelvic floor or, just looking to kind of maximize, that function. It's a great adjunct. So I would love to see more people like yourself in this space as well, because I do find that it really has been a huge help to us.
You're very kind. I appreciate the kindness and your compliments. Thank you. And I'm sure many of my other colleagues thank you as well. So, lastly, just before we kind of segue to barriers for care, is like ultrasound. I'm not sure what your thoughts are on using. I know that's probably not a wheelhouse that many urologists will use kind of in the office as far as therapeutic ultrasound. Physical therapists use that as a modality for soft tissue injuries and such. And there's one randomized control trial that came out, Jo Melios and her group. She's a huge advocate in the men's health world as far as a physiotherapist from Australia. But she had a study that just came out that showed some really promising results as far as using ultrasound over 4 to 6 weeks directly on the tissue to help with that plaque and decreasing it. So I wasn't sure if that's something in the urology groups that are talked about or known about. So I was curious.
Yeah, no, I would love to do that. I would say not from a therapeutic standpoint. So shockwave in the kind of acute setting for Peyronie's disease does have, some application to kind of reduce that acute phase when in phase, meaning when guys, potentially may still be in a state of pain, but once they're out of that phase, that's certainly not something I would say that is commonly, maybe there's someone out there doing it, but that's used to do anything directly to, the plaque. But, what's great about Peyronie's disease, as I mentioned before, we're still learning so much about it. So I think, possibly in the next couple of years, we may see, even more kind of research and other technologies to address, to kind of address that plaque directly. But I can't say that there is anything widespread or utilizing that therapeutically to directly kind of break up or deal with the plaque.
Right. Well, thank you. It wasn't meant to put you on a spot at all. It was just something that I read recently. I know we were having this conversation and I was like, I wonder if this is talked about in the urological groups, as far as what other potential options are out there for Peyronie's. And I'll make sure, I know it's an open access article, so I'll link it to the show notes for anybody who wants to read it or learn more about it. But yeah, ultrasound therapies, therapeutic ultrasound therapies has some promising outcomes. So I appreciate you addressing it.
Yeah. Again, I think probably in a year when we have this conversation or so, there's going to be even more, research and, kind of more applications. And I think the more we can do for patients, the better. So why not?
Yeah, absolutely. Collaborative care. Really, it's all about teamwork. So, cool. Well, lastly, and I know I don't want to take up too much of your time. So gracious of you to being on the show, honestly. But barriers to, we've kind of peppered this in through our conversation, but from your perspective, what other barriers, other than obviously the perhaps shame or embarrassment or the lack of resources or knowledge, in your perspective, what other barriers do men experience or have when they're seeking care for their sexual health concerns or pelvic concerns?
Yeah. So, I mean, I think one big barrier are providers, actually,
Mm.
us. I think, surprisingly, a lot of, physicians and, other, providers really don't feel comfortable talking about sex. So I think, imagine, guys not even wanting to admit that they have an issue. Imagine going to, your internist and, maybe saying, I think I may have an issue. Some people just don't like talking about it. And so I think we also have to push the education around our own, kind of amongst our own colleagues and being comfortable talking about this and also asking the question, if someone is embarrassed about something, they may not necessarily be volunteering that information. And so I think, a lot of, where I trained for fellowship, we're trying to think about what are different things that we can, kind of infuse within the pathways of care where we're ensuring that these questions are being asked and that patients' needs are being met. It should be, when we're thinking about kind of sexual history and sexual health, this should really be on the line of questioning when you're asking someone about, your family history, your social history. Like, we should be asking these questions. And I think oftentimes, unless someone, brings it up, it's not asked. And I think, sometimes I've certainly, encountered patients who are like, I've been saying this for years. I've been trying to bring it up, and they're coy. And then some, so I think we can certainly do better on the, kind of the giving side of medicine in terms of asking the question. I also think that, misinformation is also a huge, huge problem when we're thinking about barriers to care. I'm sure for anyone listening to this, you could probably go to a gas station and find some concoction for erectile dysfunction. And I can certainly say that I have had, guys who are probably have no problem potentially trying that. But then by the time they get to see us, there's a little bit of a dance around, why don't we try this? Why don't we try this? And so I think, unfortunately, sometimes, maybe talking to your friends is helpful and knowing that, okay, I'm not the only person going through this.
Right.
But I think there's a lot of poor information that's also shared amongst groups, and that doesn't really lead to solving the problem and actually leads to, other worse things where it's like, well, I tried this because my friend did it. And like, maybe it worked for your friend, but not for you. And I think also with the internet, it's so easy to go down a rabbit hole of misinformation with, certain, chat groups or, places of, people that are not experts in the field or experts in medicine or anything that are giving information. And I think guys are grasping onto this as being gospel, so to speak, and never really kind of going to someone with real information. So I'd really implore all your listeners here, anyone listening to this, please, for like accurate medical information, just please see a doctor. Even if you can't get to someone like myself who really focuses on this, just seeing, your physician should still be able to give you, I think, good, accurate information about this or point you in the right direction. But it's just interesting how I think that socialization of information happens with men. And I do feel like it's very different amongst, women in terms of what's being shared, but then also what happens after that information is being shared. And I think this is part of why we don't see guys for a long time, because they are getting, a lot of information from each other or just not, seeking it out. So please see someone. I think, for people like myself who really enjoy treating this, who really enjoy kind of helping to improve that quality of life, and good information is important. And I think it's really key that you seek it out for people that know what they're doing.
Absolutely. Well, on that note, Dr. Denise, speaking of reaching out, how can listeners connect with you? Where are you in the world these days? And if they did want to connect and have you as their provider, how can they connect with you?
Yes, well, I am in Chicago now, and I am at Loyola University, serving as the director of male reproductive medicine. And so I'd certainly say for anyone in the area, I am there, and we have, great urologists, great group there. So if you want to seek me out, just please seek me out there. And on the web space, I'm at Denise_DDOC, still working on kind of changing a little bit of my social media. So just follow my page, and there'll probably be some updates there. But yes, I'm in the Chicagoland area, but And
Hometown.
Yeah.
Shout out to Chicago.
Yeah. So anyone in Chicago, yes, I'm here at Loyola. So would love to see everyone out there and to at least get these discussions going around, your sexual health. And I know we didn't talk about this before too, but also male infertility is an area that I'm trained in, that I work in as well. So for our guys who are trying to start families and, maybe thinking about that too, I also see that side of things.
Wonderful. Well, I will definitely link your contact information to Loyola Medicine and also to your Instagram page. And I do hope that everyone kind of listening takes your words of wisdom and really takes it to heart as far as, not just living with it, but really there is hope and there is help. And so if anything from this show, I hope you've gathered that. And we're here to, Dr. Denise and I and all these other health providers who are passionate about what they do are here to help and be your support and guide. So
help you be your best self.
That's right. That's right. Dr. Denise, thank you so much for being on the show again. Really appreciate you being here.
Thank you so much for having me. And I hope this information was helpful for all the guy listeners out there and their partners as well. If you listen to this and you think your partner needs to listen to this, make them go and see someone.
That's right. Yeah. Give them a little nudge or shove. Anyway, yes. And to all our listeners there, thank you so much for spending this time with us. As always, in loving wellness for your pelvis, this is Dr. Susie G. Until next time.
Thanks for listening to today's episode. Be sure to head on over to drsuzieg.com where you can get more information, show notes, and related articles on today's topic. Also, if you like what you're hearing, head on over to iTunes, subscribe to the podcast, and leave us a rating and review. We'd love to hear feedback. Thanks again.